trying to think about a real life example of whether it's a patient story or how a service is running. And we're really pleased that colleagues in this team are able to help us focus on mental health, which we do think from the pandemic has been one of the most important areas of need highlighted. And we know there are plenty of challenges. Is it all right, without further ado, if I just pass straight to yourself, Dominic, whilst I quickly sort my IT issues out?
Yeah, no, that's fine. And I was going to ask Louise if you've got the slides to share. That would be helpful, or if you need me to share them, I can do that, but it'll be a few minutes.
Yeah, I'll just, sorry, I haven't got them.
Would it be easier if I had to go at showing them, Louise, or are you nearly there?
Nearly there, I think. Sorry, I didn't listen.
Okay, well, while we're waiting for the slides to come up, some governing body members who also attend our Quality, Safety and Risk Committee some months ago asked for some updates and assurance around some specific areas to do with the commissioning of our mental health services. So I'm going to do that today, but with a focus on 3 specific areas that updates were asked on. And that's children and young people's services, autism and ADHD assessments in the neurodevelopmental pathway, and then the improved access to psychological therapies, or our IAP services, particularly focusing on some of the challenges we have in Newcastle, but also the expansion in the Gateshead pathway. Now, before we start, it's probably important to say that mental health services are vast and complex, and many of the challenges that we have with some of the service delivery existed pre-COVID, but have been exacerbated as a result of COVID. So, for example, we have seen referrals for children's mental health services increase significantly. Eating disorder service referrals have gone up significantly, and the capacity to respond to that need has been impacted on by the new ways of working and some of the limitations that the COVID pandemic has presented. So if we could move on to the next slide. Has that moved on for anybody? It hasn't moved on for me yet. There we go. Children and young people services. So the children and young people's services, in terms of access to the sort of second tier of services, which we're calling getting help and getting more help, which is those children with and young people with more complex needs. We have a lead provider arrangement, and our lead provider is Cumbria, Northumberland, Tyne and Wear Mental Health Service, and they provide that first level of clinical triage and assessment to work out what the level of need is for the child, and then they signpost and pass the referral on to a number of providers from the voluntary community sector, which includes Streetwise and Barnardo's, amongst others, that then provide a therapeutic input for the child in question. Now, we have significant weights in that pathway. We're very aware of that, and in the paper that is with item 11 on the agenda, you'll see what the extent of that weight is as best as we can assess it. Now, it's probably important to say that we are still trying to rationalize the waiting list data here, and that we have a picture that is not yet fully reconciled between CNTW and the various providers, but that's something that we are very aware of and are working on, and hope to very soon have one version of how many children are waiting and what the average waiting time is. But I wanted to say something about some of the other initiatives that the CCG has commissioned in recent years, and one of them, which, again, if you look at the paper on item 11, has been very well rated, called Couth. And Couth is an online counselling service for children and young people. They have to sign up for the service, but it's extremely well rated. There is opportunity for one-to-one online counselling, and that's not dissimilar to what standard services have had to do during the pandemic. And the Couth service does have the ability to refer on to more formal local services should that need arise. So you'll see again from the paper that we submitted that there's significant numbers of children and young people using that, that a very high percentage would recommend it to their friends. Most people come back and use the service. It can be chat, it can be self-help, or as I say, it can be one-to-one counselling. Autism assessments and post-diagnostic support for children and young people is a particular area of pressure at the moment, and that's for two reasons. Firstly, awareness of autism spectrum conditions is increasing all the time, and people are being referred in hugely increasing numbers for this service, and the capacity for the services to identify autism spectrum conditions has been impacted on significantly by the pandemic and changes to the service staffing models in recent years. So we've been working with the various providers, and just for orientation, children and young people below school age are assessed through paediatric services in both of our acute trusts, and then beyond school age, it's CNTW that are the main provider of assessment. In order to relieve some of the pressure that is building up in this service, we have engaged the services of the Toby Henderson Trust, which is a local autism-based charity that has the capacity and the clinical expertise to do some assessments, but particularly post-diagnostic support is probably what they are mostly offering into the equation at the minute. The CCG has met with all of the providers of the autism assessment pathway recently, and we have set a vision really that we would hope across the life course, so that's children, young people and adults, that we would work towards an assessment being offered within 3 months of referral. So we're very far from that. It's got to be said at the minute. It's typically a 12 to 18 month wait for autism assessment. But that is our aim in terms of a new service model that we are asking the providers to develop. The other thing to say is that we are aware of a preschool diagnostic backlog, and we are putting in some extra resource immediately really to try and help address that, so that children and young people who may rely on an autism assessment in order to have the right educational support going to school can hopefully get it in time. It's also important to say that this year is significantly different to previous years in terms of NHS funding for mental health services in general, but children and young people's services are very specifically part of the new funding that is being offered, and that there is really a sea change in terms of potential investment into mental health services that we as commissions can use to develop the services and address some of the challenges that we've been aware of. So if we could just move to the next slide. So I've said a lot of this, I think, in the children and young people's slide anyway, but obviously autism can present or can be suspected at any stage in life, and we're aware that we also have waits in the adult pathway, and that attention deficit hyperactivity disorder, ADHD, is also an area where we're experiencing specific pressures. So again, these are two areas that we are aware of, and in the paper we provide some breakdowns in terms of the waiting times by place. So you've got data for Gateshead and you've got data for Newcastle in that paper that shows you the extent of the wait and those that are having to wait more than 18 weeks, which is a significant number at the minute. Things are improving. So if you look year on year at the data that was provided in those graphs, things are getting better in terms of how fast people are being seen and the numbers being seen in the service, but it's still not keeping up with the demand. So additional investment will be required, as well as potentially the waiting list initiatives that I've already mentioned. But also we're looking at other providers that might be able to not only just provide the assessment, because the assessment is one thing, but that post-diagnostic support or treatment initiation, if it's ADHD, is important as well. So we're keen that if additional providers are brought on board, that they can provide the whole of that it's not just the assessment and then back into the waiting list. So that's quite important. So if we could just move on to the next slide. So improving access to psychological therapies or IAPT is something that has been an initiative for some years, but this is where most people will sort of access mental health services. It's a basic, usually cognitive behavioural therapy or CBT based intervention for a short period of time, 6 to 12 weeks, but it is a very important service because it's something that can identify more serious problems early, but for the majority of people, this provides a very effective response to anxiety, depression, OCD type problems. Now, in Newcastle, the service is provided by an alliance of 3 providers, CNTW, the mental health provider, Newcastle Hospitals, and Mental Health Concern, which is a voluntary community sector provider who is part of that alliance. Their waits to see people are extensive. So whilst we know that they can do a screening phone call and signpost from that screening phone call within 6 to 8 weeks, which is within the national targets, it then can take up to 12 to 15 months for treatment to start, which clearly is not what we would want for patients, and we have got some contingency plans that I'll talk about on the next slide. But we are working with the alliance provider to develop a recovery plan that will hopefully give us confidence that that waiting list will come down significantly. And there is funding, the funding that I've alluded to earlier, the increased funding that we now have this year. We have funding to invest in helping that service recover as best as possible. And as commissioners will be monitoring their progress throughout the year. The Gateshead Talking Therapies is provided by South Tyneside Community Services, so it's a different provider. It's a slightly different model, so it's important to sort of not compare exactly with the Newcastle service, in that the Gateshead service doesn't take any higher acuity patients at all. It's the sort of entry level talking therapy service, if you like. But having said that, it performs very well. Average wait to treatment initiation is around two to 4 weeks. And as a service, they, in line with national service specification, are looking to expand their service and offer it to more people, but with a particular focus on people who are living with long-term physical conditions. So we know that people who have conditions like diabetes or COPD have more mental health problems, and we want to target those groups specifically and encourage them to take part in a course of IAPT talking therapies, in the sense that we know that it will help minimise the levels of depression in those groups, but also it's likely to help the monitoring and control and improved outcomes from their physical conditions. So it's an important group to target, and this is the sort of next stage of IAPT expansion, which we're ready to roll out in Gateshead. Similarly, one of the original visions of IAP service was to try and help people stay in work. There's good evidence to suggest that when people have anxiety and depression, if they are supported to stay in work, they get better faster and they have more sustained recoveries. So that's where we are with the Gateshead service. We are looking to invest and expand, but we don't currently have any waiting pressures at all in the Gateshead service. So my final slide is just to talk a little bit about the digital mental health support. And, you know, even though the pandemic has meant that many providers of many services right across the range of services that we offer in the NHS have had to consider new ways of working and new ways of connecting with people. Some of this work in mental health preceded some of that. And Couth, I've already mentioned, but there's a little bit more about the Couth service there. And more recently, we have, just at the start of this month, offered an online emotional wellbeing platform for adults called Quell. Now that is provided under the Couth banner, but it's specifically aged at those over 26, and something that we are hoping will fill a little bit of the gap in Newcastle whilst that recovery plan is being implemented. So there's a little bit there just to describe what that service does, but our aspiration is that if it's as well received as the Couth service, then it will provide a very useful and helpful intervention for people that are distressed and need some support. So that's the three areas that governing body lay members had particularly asked for some update and assurance around, and I'm very happy to take questions. Catherine is on the call and can take specific questions as well. And in terms of the place-based plans, I'm sure Lynn and Jackie will answer any detailed questions in terms of service development at place. So happy to take any questions.
Fantastic. Thank you so much, Dominic, and Catherine, thank you for joining us. Catherine, is there any other points you wanted to make before we go to questions? I think Margaret's first, if not.
No, thank you.
Okay, straight to you, Margaret, then, if that's right, and then we'll come to you, Liz.
And that was really helpful and really clear, Dominic. And I think it would be good to see the maximum waiting times when the data are reconciled and they're able to be shared. I mean, my concern is that the size of this problem, that waiting list initiatives on their own are not going to be able to solve this satisfactorily. And you've talked about maybe bringing other providers onto the market. And I just wonder, are those other providers out there? And what is the view of CNTW? Because if you saw money being available and this huge waiting list and you are the main provider, why is CNTW not offering to resolve some of this backlog?
So I think there are a few questions in there. So CNTW are certainly working with us and looking at the backlog with us. And in terms of waiting list initiative, that is only part of the solution, as you're suggesting, and we're very aware of that. So the waiting list initiative is just to try and address some of the immediate problems, particularly in relation to the children and young people who are awaiting autism spectrum condition assessments, particularly the ones who are due to start school in September. We're very keen to move very quickly on that for the right reasons, but that is not to the expense of a more sustainable long-term solution. So we need to do both, and we are doing both together. The Trust is very keen to work with us and with other providers looking at solutions. But yeah, there necessarily might be some competition. But you know, if we can do it as a collaboration, as an alliance, that is always more helpful. And Jackie may have something more to say about the sort of provider commissioner collaborative conversation that we think is developing very positively in Newcastle anyway.
I'm not sure I have anything to add, Dominic, more than you've said there, really.
Okay. Any other points that are on this particular issue, or as we did in the previous meeting, I don't know if people just quickly mind putting their hands down if it's not about this issue, then we'll come to you in a second. Okay, everyone is about this issue. So in which case then we'll go to you, Liz, then we've got Lynn, then Jeff, then Mandy, sorry.
Thanks, Dominic, for that. That was really good. I just want to ask a question about adult psychiatric services and personality disorder. Is there any plan to offer, therapy for personality disorders? This is a huge problem really for a lot of people in my practice, and I imagine other practices. And they often think they've got bipolar disorder, but in fact it's a personality disorder, and we know that dialectical behaviour therapy can be quite successful. What is the provision for personality disorder at the moment? Because I'm not sure if it actually exists, if there is any provision for it. So I'd be interested to hear your thoughts on that, please.
Yeah, so interestingly, and I too have similar challenges with similar patients. Certainly some of them I think can be helped with Talking Therapies Gateshead, and they do provide some basic DBT and some interpersonal therapy as well, which certainly for some of my personality disorder patients has been really helpful. But as to a formal DBT service, which I think is the gold standard, that is not part of the IAPT spec, and I think it is a deficit that we need to sort of think about how to address, and something we can take forward in our conversations with CNTW and other providers. But Catherine, you may have something more to add about DBT availability.
I think the community mental health transformation is very much focused on people with SMI and certainly personality disorders, or as it's more broadened out to that spectrum around personality disorders, is very much part of the transformation this next 12 months. So we've been working with CNTW and have reviewed the Personality Disorder Hub, which is the specialist hub in CNTW, and are now looking at the community pathways to go into that hub along with the psychological therapies that support that. So it is in draft format at the minute, but absolutely happy for comments in on some of that, and we'll bring that back as we develop it. But it's certainly on the cards this year.
Thank you very much. Lynn, I think you were next.
So I think Dominic's already covered, but there are some arrangements in place in Gateshead, as we've still got identified gaps in support for people and families, both pre and post diagnosis. So over the next few months, we've got a review. Elizabeth Morris from Next is going to lead this, and it'll take place to support the Gateshead system and hopefully lead to the development of a proposal to improve the offer across the whole of the life course. But we will be working with the VCS, and Catherine assures us that we've got some really good providers out there who can do assessments. So we can look at the alternatives to probably what's more of a medical model that we're looking at, and have some kind of hybrid model. I'm hoping we might even have some GPs out there with a special interest who, we can pull into that work as well. Ever the optimist, but I think it's a real opportunity to look at how we do contract currently, look at that block contract, and look at the art of the possible and what we could do differently.
Thank you very much. I think Jeff was next, then Mandy.
Thank you, Mark. Yeah, just a couple of questions. Dominic, very interested to hear your commentary about diagnosis of preschool children. In the charity I work for, the charity owns and runs a children's day nursery, and we are seeing significantly more children coming into the nursery who display symptoms of ADHD and autism, but there's absolutely no resource and no funding to work with those children to get a diagnosis, and very little in the way of service support from the local authority in the area in which it's in. So, and it just sucks up so much resource of the nursery that it makes providing a good service to all children really, really difficult. So anything that is being proposed to support nurseries to get a diagnosis preschool would be welcome. That's my first point. My next question is, I think the governing body have recognised for a number of years that there is a problem with mental health services, and that problem is being manifested by a significant waiting list. But in all the conversations we've had, I don't think I've heard what the root of the problem is and what is causing the problem. Just that we have a problem, and the symptom of the problem is significant waiting lists.
Right, well, on the first one, the preschool assessment for autistic spectrum conditions, that the pathway is not proposing to change. It's just proposing to sort of try and address the backlog, and that's via paediatric referral via the GP. But there probably would be opportunity to look at more broader pre-diagnostic support from charities like Toby Henderson or similar, for where it's suspected and that referral hasn't happened yet. So we're very open to sort of looking at that as a system, really. What do we do when nurseries are sort of struggling? That's absolutely in scope. In terms of the what is the diagnosis for the problem in mental health services, that's I think quite complex and historical and political. I think mental health services have for many decades been underinvested in compared to acute secondary care services. So I think they have always been a Cinderella service. Now that's something to do with mental health stigma. It's something to do with the way the services are set up and their expectations. They didn't take part in any of the sort of waiting list target based work that happened in the early 2000s when we saw all the other waiting lists tumble. Mental health services were ignored, and even during my time with NHS England, when there was more investment being sent out with the intention that it was used for mental health services, when it was analysed, many CCGs around the country hadn't spent it on mental health services, and that was what led to the introduction of the mental health investment standard, whereby the money in the CCG baseline that has to be invested in mental health is ring-fenced and increased year on year, and that's part of our increased funding this year. So some of it is perceptual, some of it's political, some of it is chronic underinvestment, and then there is also a huge amount of complexity, because even though most mental health providers in the country are on large block contracts, there are so many service lines within those block contracts that invariably need investment at different times and for different things, that we end up in a very complex contracting and commissioning arrangement. So that's just some insight and observations as to why we have a problem. It's not the whole explanation, of course, but it's just some of my observations as to why it's harder for mental health.
So would it be fair to say that the best we can do as a CCG is in the next 10 months is to hand over an accurate data set and not have a full understanding of the problem?
I think we can be more ambitious than that, Jeff. I think we can improve the data set in terms of the waiting times and the average waits, but I think the dialogue that we've established, the constructive challenge that we are putting in, and the shared vision and ambition to do things better, I think we will definitely move forward in the next 10 months in some of these areas that we've described this afternoon.
Okay, thank you very much. Mandy next, then Jackie.
So first of all, obviously I declared an interest because my day job is CEO of Streetwise, so I'm one of these commissioned services. Secondly, I wanted to say that some of this funding has followed early intervention and preventative services, of which Streetwise is one. So we have no waiting list now whatsoever at Streetwise because the funding has followed early intervention, supported by Catherine and Jackie and colleagues at the table. So I would urge that we don't go outside of our current providers. We fund them correctly and appropriately in the first place, because we've waited 3 years to have this funding uplift in Streetwise, and the results are absolutely instant, as in a young person can be referred to Streetwise this week, will get an assessment within a week and into therapy within 2 weeks, which is a massive, massive shift of what has happened recently. And I can echo that with some of the other VCS providers that are in our patch. So for me, it's like, please don't go to external providers until you really do fund your current provision in Newcastle and Gateshead already. It just goes to show that if the funding follows early prevention and preventative services, Jeff's sort of comment about catching early, looking at what the causes are, what the results are, and the turnaround is phenomenal. So I would just echo what colleagues have said around sort of like making sure CCG funding and CNTW funding goes to those organisations, not just internally but externally on their doorstep. So obviously that's a sort of like a quick return from Streetwise in just a month or so of having additional funding. But this is non-recurring funding. You know, so I've got another 3 counsellors at Streetwise that have been able to provide early intervention and CWP support for younger 11-year-olds early as possible. But I would really ask the CCG, like Jeff and colleagues have said, to look into this and get the real picture of what's going on in our communities, rather than keep buying more and more and more from external providers. And I'd like to put it on record that Catherine Richardson's been absolutely instrumental in steering this to those providers that have been waiting to be able to respond as quickly and as efficiently as possible. And just an air of caution on Cooth. I think Cooth is brilliant for those young people that are IT literate and confident, but there are a lot of young people that are still insisting on face-to-face counselling at Streetwise and other projects because they cannot talk about trauma, abuse and sexual assault from their family home, and it just feels like they just don't feel safe to do that. So it's and so for me, we need to have that offer of services across the board, and not just rely on, you know, online, you know, sort of like specialist. It needs to be a generic service providers across the piece, really. So obviously I'm going to say that because I've got my CEO head on in terms of Streetwise, but just to say there's some fantastic services on your doorstep that just need funding adequately and consistently.
Thanks, Mandy. Shall we pop to Jackie next?
Yeah, it kind of builds on what Mandy's saying. So Children and Families Newcastle is absolutely about that. It's about early intervention, about children's emotional well-being. It's about working with the voluntary sector and clearly being focused in getting there, identifying early, working with families. The notion of the family partner that we've invested in as well is to get that early intervention going. So reassurance that we are looking at the voluntary sector and local supply. The other bit I wanted to pick up on was Jeff's point about ASD, and just to reassure him that it is one of the highest priorities for review within Newcastle, to be done jointly with the local authority. The pre-diagnostic support that we're putting in at the moment is absolutely about getting those kids ready for school in September, but that is only the start. It's an interim measure so that we can look at exactly what we need to do. So
Thanks, Jackie. I think we're on to Oliver next and then to Mark.
I mean, just to reiterate, I think the points about early intervention, but in terms of diagnosing the problem, I think for me is that people don't leave services. Services didn't ever have outcomes that led to people leaving. I came into services when I was 7 and I was discharged from services in January. That wasn't because I'd made any improvement. It was because I was told there were COVID pressures. You know, that's not a good service. And there's no measures or outcomes that actually hold providers accountable for people's lives changing. Too often the measures are metrics that work for a provider. And if we develop metrics that actually deliver change for people and get them, you know, out of the waiting lists and actually into life, that's where the change comes. Otherwise you have continually pressured capacity because no one is actually, you know, having change. I think some of that is the workforce, that there's not enough people to actually deliver work one-to-one in a person-centered way. So looking at that sort of transformational change is really important. But just to sort of caution sort of the personality disorder hub, I suppose, is it exists, but you know, you're not eligible for other services because you have a personality disorder, but you're not eligible for the hub because you don't meet the criteria. And that's a trap that people really fall into, and it's not something that we should be allowing, really. It's a gap in services, and there's been many reports on the people with personality disorders being really segregated and discriminated against actually within services, and we need to make sure that we don't perpetuate that. Sorry, my camera cuts off as soon as I turn it on.
Oliver, thank you so much for sharing that very personal story and absolutely some very powerful points there, and I really appreciate you sharing that. I think we're on to Mark, then on to Joe next.
Firstly, also from me, thanks for sharing that, Oliver. It's really helpful for us to understand and know that kind of detail. The point I wanted to make was just following up a little bit on what on Jeff's ask to Dominic about, what could we do this year. I'm not going to rehearse what Dominic said, but it was just to make the point that there is a huge amount of effort focused on how we develop and how we put services back in place, and that is creating a momentum in the system. And I think one of our hopes is that momentum will allow us to also do some things in areas where we know that we've had some problems for quite some time, like this. So hopefully that momentum will allow us to do more in the time that the CCG has, and try and move this agenda on in that 10 months. Thanks, Mark.
Thanks very much, Joe.
I was just going to say exactly what Mark's just said there. What can we do within 10 months, and let's be realistic about that, and let's be robust about that. My other question was probably back to Mandy and to Catherine. I mean, Mandy, you've just articulated a game changer in terms of recent months, and I'm just interested, is that, and again, I don't know if this is a question to Catherine or to Mandy direct, is that because the funding in the recent months we gave direct to the third sector?
If you want me to go first, yes, Joe,
Okay.
directly. I mean, to be fair, we've had a standstill budget for 3 years from CNTW. So in offence, that's a cut, because my counsellors and my services don't have a standstill budget in the voluntary sector. So it's not a full cost recovery grant. And I think we've constantly put pressure on CNTW to follow the model, which is, follow where the direct need is in terms of upstream. And I think from Catherine's point of view and our consortium's point of view, we've made that point very clear with CNTW, and they have followed the funding upstream, Joe, which has been absolutely critical post-COVID for a lot of young people that you would not ordinarily know that they would be struggling with social anxiety and depression as a result of COVID, but they're coming through the woodwork. And I know that single point of access are not seeing any release of the referrals coming through the sort of like their doors at the minute. I only had a meeting last Thursday with them as part of our fortnightly meeting with CNTW, and it's constant. There is no decline in the numbers coming through the SPA at the moment, which we thought would, as schools started to sort of like establish themselves, Joe. So for me, the writing's on the door. We've seen an immediate response, following the funding.
Yeah. I think that needs to be a takeaway message for the executive. Thanks.
That really is. Thank you so much, Paul.
Yeah, I'd just like to follow that point really, because I think we've got a lot to learn from it. It was very disappointing the way, I'm presuming from my perhaps lack of information, the way CNTW dealt with the IAP in Newcastle. Long-standing problem. And it seems they were almost pressurised into being much more flexible and giving out more money to other providers who've then been trying to help solve some of these problems as well. And that's thanks to the work in the CCG. So I think we really need to learn from that and make sure that within contracts like this, people are much more flexible in the way they sometimes approach problems that are happening at an earlier point, and using that kind of capacity that we do have in places like the voluntary sector.
I agree.
Okay, so that's felt a really good debate and discussion, and thank you so much for lots of really positive comments. Catherine, Dominic, are there any closing comments you'd like to make? And Paul, did you want to make a further point just before they do that?
Sorry, yes, I was going to ask a question now because I was, trying not to do the other questions. It was about the how long is it really going to take us to get the assessments for people with autism and ADHD down to a reasonable level now? And I know there's a lot of work trying to kind of even speed what we're doing up even further.
Yeah, so it's probably too soon to tell you how long it's going to take to get to that 3-month ambition for an assessment of anybody of any age. But that clearly is what everybody agreed on, was a reasonable time space for a wait for a formal autism assessment. So our priority at the minute is those children who are awaiting starting school in September. So that's the waiting list initiative group. But then we've asked CNTW to lead the sort of service development proposal, if you like, to come back to us to say what would it take to get to this 3-month vision for assessments. And I've said they had 3 months to come back to me with that proposal. So we're probably about 4 weeks in now, so they've got 8 weeks to come back to me with the proposal for what it would take, and then we start the review of whether the funding streams we have support that, and what else we can do if there's no direct way to expand the service. So how long will it take? You know, I would certainly hope we have a credible plan to put into action within the next 6 to 8 months.
Thank you. Catherine?
I was just going to say, Paul, and probably to reassure Mandy as well, that the comment in terms of other providers, I think probably wasn't aimed at the children and young people, you know, range of providers we've got. I think they're fantastic. And I think for probably ADHD and ASD, we've had CNTW in for a long period of time doing those assessments without any of the post-diagnostic support that we envisaged. What we have seen, though, is some additional providers that are coming in under a kind of right to choose type of approach that patients are requesting those GP referrals for. So I think for ADHD and ASD, we probably have got a range of providers that we can utilise to try and help us with those waiting lists as well.
Thank you. So thank you very much for that update. Dominic, is there anything further you wanted to add, or have we now finished items 1 and items 11?
I think we're finished, but happy, you know, as always, to have questions outside the meeting or as we go along with the work.
Well, a huge thank you to you and to the team behind that are doing amazing work. I know it's such a difficult area, and we're really grateful. We've obviously let that agenda item flow a little bit longer than we'd timed, but I do think it's such an important area that we do that. We're going to go back to our main agenda, and welcome to those that have joined us. And sorry for colour, because in public health we did just start slightly earlier. I hope that message, I appreciate that message may not have got to you, but apologies for that. Firstly, apologies for absence again, Louise, if you don't mind just putting in the chat function if there's any apologies we need to note, and then I think it's just checking the quoracy for any decisions we have to make, which I understand from Neil that we are quorate, and then it would be moving us on to the minutes of the previous meeting, so item 5. First of all, in terms of accuracy, any particular points in terms of accuracy? Because then I guess we do need to discuss one of the matters arising from that minute, which is around the Gateshead agreement, and just in terms of some of the actions that have followed from that. First of all, accuracy, if there are any points, just put them in the chat function or raise your hand. No. In terms of matters arising, I guess I'd like to give my thanks to the LMC who have been helping us try and explore a way forward for this. We have had a number of different discussions, both with Paul and with other colleagues, trying to think of what ways that we can get the Gateshead conversations better, and then also thinking about the separate points of representation. Apologies to colleagues that when we had our last meeting, I think I was informed of a slightly different version to what other people were, so apologies for that, and thank you for colleagues for bearing with us trying to find a way through this. We have 2 particular actions. One is that there will be a forthcoming meeting between the leads of PCNs, the LMCs and the CCG, trying to make sure we can get the widest sense of primary care representation, but having that small group to try and find a way through this, recognising that sometimes our other meetings have all been very much focused on the PCN element of primary care rather than the widest sense of primary care. At the moment, there is a pragmatic agreement from PCNs around how the representation is going to continue pending that meeting, and as I say, there has been a variety of meetings behind the scenes with LMC involvement around the PCNs working and their representation of primary care into the system board. So whilst it's not concluded, there is quite a number of actions happening. I guess the other thing, just to perhaps update colleagues, is that we also have a leadership meeting each Tuesday morning at 8 o'clock, where previously we've done it across Newcastle and Gateshead, and we've just agreed this morning that we'll now have a place-based part of that, which again has the same leaders of PCNs, LMC, CCGs, all as part of that conversation. And we hope that gives more ability for us to continue to transform this journey in a collaborative way. Are there any questions, any comments that people would like to make at this point? Nope. Are there any other matters arising from that minutes that anyone else wants to mention? Okay. in which case then we're going to pass across to Mark. Thank you very much, Mark, for taking us through a quick update from yourself as Chief Officer.
Thanks, Mark. Firstly, thank you to everybody for all of your continued efforts. Even though we are hopefully moving to new places in terms of the pandemic, it feels no less busy with all the challenges that we have to face. Still, lots of work for us to continue to do in terms of vaccinations. While we do that, and the country turns its attention to lifting some of the restrictions, we also have to be mindful that there are new strains and variants emerging, which are starting to cause concerns and problems that we continue to need to be vigilant about. It's also the case that as we're moving hopefully to a new place in terms of these phases of COVID, we are looking at recovery. Recovery in terms of the services that we need to put back in place, recovery in terms of the nature of those services, the way that they are delivered, and not least how we start to tackle the backlog of patients who've been waiting on waiting lists for operations and procedures, etc. Whilst we're doing that, it's also the case that we still need to be mindful about some of the business of the CCG. Very recently, and just coming to the end of the processes that we have to do in terms of our annual accounts, finances, annual reports, etc. But we're also engaged very actively in all of the continued planning work. And this year, with the regimes that we've got put in place, the planning covers 2 periods. We're no longer talking about Q1, 2, 3, and 4, where we're now talking about H1 and 2, half year 1 and half year 2. And our planning work thus far has been focusing on the first half of the year, and we'll be engaging in second half of the year planning. And part and parcel of that is trying to understand the financial regimes and the changes to the financial regimes as we are on a path back towards what we would normally expect to see in terms of finances. With all of those things going on, we also have a lot of work, as you can imagine, and we have previously discussed in terms of thinking about moving to a new way of structure and ways of working in the NHS. As we've discussed before, there will be a white paper going to Parliament this year. The expectation is there will be 2 readings of that white paper before the recess at the end of July. We continue to work with colleagues across the whole of the ICS and across the 4 ICPs in terms of thinking about what a new way of working will look like. What an ICS will look like when the CCGs come to the ends of their corporate existences at the end of March next year. But in order to take that further, we are awaiting guidance. As we've discussed before, that guidance we are awaiting for is under 4 headers. One, in terms of what the ICS will look like and the expectations of an ICS, constitution, structure, etc. Secondly, in terms of the financial regime. Thirdly, in terms of data and data architecture requirements to support the workings of ICSs and place-based working going forward. And finally, in terms of HR and the commitments to staff and the HR frameworks that are going to be put in place to take staff from employment in CCGs towards employment in the new structures in the ICS coming forward. We're hoping to see some of that guidance as the white papers go through Parliament, but the expectation is a large amount of that guidance won't be available until after the 2 readings in Parliament. So still awaiting that guidance, however, work goes on behind the scenes in order to understand what we can do and what we can think about as we wait for that moving towards that new system at the end of March. So I'll stop there, Mark. I'm happy to answer any questions.
Thanks very much. Just before we go any further, Michelle, apologies. I thought we were scheduled you were later on, so many apologies if I've misunderstood the timings for yourself. and Michelle's gone. Okay, we've lost both of our public health input then. Sorry, Mark, we'll come back to that in a moment then. So has anyone got any questions for Mark? I can see Liz has got a hand up. Liz.
Yeah, I just wanted to know how many staff have left the CCG due to the uncertainty of the transfer over to the ICS?
So I don't think that we have seen staff moving because of particular uncertainties. We still see staff moving around to new positions. So what we are what we're not doing is stopping the development of new roles and posts while we're going through this process, because we need to make sure that we've got people in the right places doing the right things to support the development of place-based working, but also the challenges that we've got right now. But we're not seeing large numbers of staff moving around because of the uncertainty, if I'm honest, at this point in time. Joe, can I pass across to you for anything else that you want to add to that?
No, pick it up on the HR report, but certainly of the exit interviews, no member of staff has said that this is the reason for leaving. And I can pick up the reasons for leaving in the HR report. That's fine.
Okay, any other questions for Mark? In which case then we're going to go to our patient and public section, and Mandy, I think you're leading us through this paper with Paul.
I think Paul's taken this one. Mark,
apologies.
That's all right. Yeah.
Go for it, Paul.
Sorry, I'd assumed you were doing this one, Monday.
I did it last time.
Oh, I thought I did.
Excellent. Excellent.
Right. I do apologise. Hold on.
I guess if neither of you are expecting to go through it, are there any particular salient points either of you wanted to highlight that, even if we're not going through it in a formal way?
I mean, based on time and Mark, unless there's any sort of queries or questions, I think that the report speaks for itself quite often. So I would be happy to take any sort of questions by sort of like exception, if that's all right. Other than that, I think the report speaks for itself. And the only thing that I would add is that I did chair the community forum forum last week, and there was 16 representative organisations from across Newcastle and Gateshead that all were very, very keen to understand what was happening in terms of COVID updates and responsibilities that they can take into some of our seldom accessed members of our community. So from our BME community, from our visual impairment communities, and I'm really keen to keep that group going and keep the conversations open with communities, because they are very, very keen to make sure they're doing the right thing.
I agree with Mandy. I'm happy just about the report as it is. Mm-hmm. What would be useful in the report, as I think we've asked before, is for them sometimes to come back and say what's happened as a result of some of the consultations. Mm-hmm. Because there seem to be a lot of consultations that we're involved in, but we don't always hear back about what's happened as a result of those consultations. Mm-hmm. So a bit more of that in the report would be really welcome, I think. Cheers.
Okay, is that something that the two of you can link in with the team? I think that'd be really helpful to do that. Julia, you've got a question?
No, just to add to the comments I presented at the Patient and Public Engagement Forum, and we had a really healthy debate about the changes coming down the path. There raised some really interesting questions, and we agreed at that forum that we're going to move to a more place-based focus. So we'll look to change those conversations and have that place-based discussion moving forwards. And obviously Jackie and Lynn will be front and centre of those conversations.
Mm-hmm.
Okay, Jackie first, then Paul.
Yeah, just to add to that, the other thing that we'll be doing is looking at how we work with partners across the system to engage in neighbourhoods.
Mm-hmm.
Okay, Paul, do you want to answer the question from Margaret about paragraph 10?
Oh, and that's a base approach. It's looking at all your, I mean, somebody correct me if I'm wrong, but it's looking at all your assets in the community that you can use in order to make better use of anything that you're doing, and having more comment and valuable comment on what you're doing, and using the resources in that community to help you then achieve our main objective, which is improved health and well-being.
It's the opposite of a deficit approach, where you focus on what you don't have and the poor outcomes and the poor services.
And it's about positively using those resources in the community as well, and really going out and outreaching to them. Sorry, I just wanted to add, I think I wouldn't be forgiven by the forum if I didn't mention that one of the things that they believe that we really need to get good connections with is the patient practice forums. And there is a feeling that really that needs to be more work done in lots of GP practices to get those going. So, and that's certainly a very strong feeling amongst most of the members, because they see that as a good collective way of getting things working and engaging them not just on the practice issues, but on the practice network issues and on the wider health issues. And so therefore there needs to be more emphasis on supporting GP practices to do more about those groups, I guess is what they feel.
Okay, thank you. Jackie?
Yeah, I mean, I don't disagree that it's important for them to link to practices, Paul, but I do think there is something about being involved in a broader discussion and engagement process at PCN stroke network level, where they can really talk about that non-medical approach to care, which is really, really important.
Okay. Are there any other comments then on this section, or are we able to move on then to section 9 and say thank you again for all that work for the team that sit behind us to do this? Yep, we'll move on. Your hand's still up though, Paul, but we'll move over to Julia and then Joe around the quality, finance and performance section.
Thank you, Mark. So I think I referred last time to the challenges of making sure that we've got quality and safety systems in place whilst we've been dealing with the COVID challenge. I'm delighted to report that we have had the presentation of quality accounts from our providers, and some colleagues on the call did join me to hear those presentations. And I think, to be honest, it was really quite overwhelming to hear everything that's been achieved at the same time as delivering on the COVID challenge. So the quality metrics that we would typically look at, I think you'll see in the, I don't intend to go through the report page by page, I'll just assume people have read it. But if you think the data that's in there was in March, which was clearly when we were absolutely at the height of COVID, and the number of patients that we had, particularly in Newcastle hospitals, where we provided mutual aid to the country. I think altogether we had around about 50 to 60 patients in our hospitals from out of area. And a number of staff, if you think at that point in time, we had staff that were themselves unwell with COVID, and we had a real workforce challenge. So staff working in critical care with, you know, training, but not where they were used to working, staff moving around to providing care to our patients. So what you'll see in the data is the number of incidents of pressure damage. And we know that some of that was linked to patients that were COVID positive, very acutely unwell patients, and the equipment that was needed wasn't always available when they needed it. So there was sometimes a bit of a delay. So we've really had a deep dive into some of that. The fact that a lot of areas have maintained training during this period, again, is, you know, real testament to the commitment of our staff working across all parts of health and social care. But it's just to give assurance to the governing body that we have had that deep dive into those incidents. We've had a particular thematic analysis on falls and also on pressure damage, as I say. And then we've just recently had a deep dive into ophthalmology, because we know there was some issues with IT and some never events. And again, we've had assurance on the actions that have been taking place so far, but also the action plan moving forwards on that. So I think all in all, the incidents that are reported, we haven't had the QRGs in the same way that we might have done, but we're looking to re-establish those as we move forward. So in the few weeks that I've been in this post, I think it's fair to say that we've re-established a lot of the mechanisms that we had pre-COVID, and I'd like to assure the governing body that the report and the plans that we have in place are robust. Margaret, I don't know if you want to add anything as chair of the Quality, Safety and Risk Committee. I hope I've covered what we heard, but just interested if you want to add anything to that.
Well, I think the QSR committee has been very happy with the way that colleagues have kept going with serious incident reporting and taking immediate action if immediate action was necessary. But this was something I was going to say in the next section under performance. I am getting slightly frustrated by objectives to, for example, establish fall champions or improve serious harm from pressure sores, or streamlining pathways, or implementing best practice, as if this was something new and innovative. It isn't. And I'm just wondering, you know, can we take a step now where all of these quality and performance initiatives, can they not become part of daily management activity and best practice? We don't need a crisis to streamline a pathway or to appoint a falls champion when we know that that's needed. And let's not call them initiatives anymore. I mean, I think if I was a trust non-executive, I would be very frustrated hearing about all of this again in another year.
So Margaret, we'll share you on that. So the discussion that we've had at the SI panel, and Dominic obviously attends that too, and Bill, is around some of the action plans being a bit vague. So we're trying to make sure that we get smart action plans and a more timely response. And again, some of the responses have been a little delayed due to COVID, but we've reinforced the need to have that timeliness and the actions delivered in a smart way. So that's been addressed just in the last couple of weeks. Dominic, I don't know if you want to add to that, because certainly you were quite emphatic in the same way about the smart response, and you know, we have been quite tenacious, I think, in the last couple of meetings.
Yeah, so for those that don't know, the Serious Incident Panel reviews all serious incidents that trusts themselves review at their own panels, and it's just to provide those external eyes and clinical challenge to what they've reported and whether they've identified the correct learning. And in order for us to be assured that, you know, there is learning and there is a lowered probability of serious incidents recurring, we need to have that assurance that the learning recommendations going forward are not just vague, and you know, we need better communication, or we're going to make sure everybody gets trained. You know, it's those sorts of things that we sort of object to, that we want to know, well, how many people are going to get trained and when by, and how are you going to know that's having the impact. So more recently, particularly with the more numerous serious incidents, which are grade 3 and 4 pressure ulcers or falls that result in harm, we've asked the trusts to tell us whether the ward it occurred on, what their sort of rate of that incident is, how that compares to the trust overall, and whether it's an improving trajectory year on year, which is, you know, that they've responded to. And that's an example of a much more specific piece of information that helps us see whether we're sort of moving in the right direction.
But overall, if I may say, Chair, I think we have better quality and are safer than we were a number of years ago. So I think this work that Dominic is describing is successful, and we should be proud of it.
Good. Okay, thank you very much. Is there anything further, Julia, you wanted to mention, or are we back on to Joe?
Fine, thanks.
Joe,
if I pick up, yeah, thanks, Jeff. I just pick up on performance issues. I mean, we've talked about the month 12 financial position and contracting's being suspended. So I guess what I just really wanted to highlight is a number of key performance issues that are covered in from page 12 in the IDR report. A&E, we are struggling to get back to 95% performance, both at Gated and at Nuth. We are looking at ways in which we can improve flows, introduce observation beds again, and increasing the bay capacity to 5 beds. And these have all helped. but we are still seeing increased pressures from acuity of patients that are presenting, albeit activity in both ED departments. In fact, all 3 ED departments in the ICP is down on previous years. In terms of other areas of restoration cancer, again, excuse me, again, in terms of performance levels against the 85% target for 62 days, both at North and at Newcastle, we are falling short of that. We're currently about 75% against that 85% target, with key pressure areas in skin and breast tumour sites. We've seen increased referrals in terms of lower GI, coupled with real practical issues about scoping, and Bill may wish to say something around that. But again, we're trying to look at other mitigating measures in terms of rapid access diagnostics in some key pathways. And also, you've probably seen on the television in terms of head and neck cancers, but also lung. We are having media campaigns just to encourage patients to present if they've got a persistent non-COVID related cough or a persistent cough that potentially they believe is COVID. We are asking to get them checked out irrespective. Bill, do you want to say anything around scoping?
Well, a couple of things. Thanks, Joe. There's a meeting at 5 that I'll be at for the regional scoping group, and we're virtually ready to sign off the new advice that we'll be providing for our primary care colleagues. And amongst things will be an almost complete restriction on open access for upper GI endoscopy on the grounds that it doesn't actually do any good. But more about that when that comes out. The other thing I would say, and this is contrary to the flow of information about cancer, and I raised this for those members who were at the audit committee last week, that there's a tentative suggestion that in, for instance, bowel cancer, the number of operations that are being carried out is increasing. Now, this is a cancer whose incidence has not altered year on year. And the suggestion is, or the suggestion that's been made, is that actually the COVID crisis has made people think a little bit more about their health and their symptoms, and more people are coming forward, and therefore more are being diagnosed and therefore being operated on, because about a quarter of patients with bowel cancer are not operated on for a curative with a curative intent. So it may be that there's a vague suggestion that people are actually paying a little bit more attention to their symptoms. Now, that's contrary to what we find in head and neck and lung, but they are predominantly in deprived parts of the community, and that might well fit because we don't get access to that group of population, which in itself is another topic. So I just thought I'd make those 2 points, but thanks anyway, Joe.
Okay, thank you for press on then, Chair. In terms of general referral to treatment times or RTT, we are slowly improving against the 92% standard. Currently, we're at about 70% at North and 76% at Gated. So we are making slow progress to that 92% target. I expect that to significantly increase over the forthcoming months as we move to putting in place the elective recovery programme. We also are using the independent sector wherever we can, and this morning at Exec we've just agreed to extend a further 9 months the current contracts for the independent sector. Probably just an interesting point to make in terms of the waiting list. At Newcastle it's around 80,000, but 12% are electing to defer their operation either on the basis of just patient choice or on the basis of COVID concerns. So that's 12% of 80,000. I thought that was an interesting observation to bring to the table. That's all I wish to say, Chair, and invite questions.
Fantastic. Thank you very much, everyone. Any questions from anyone? Okay, go for it. Sorry, my hands are not showing whose hand is up. Michael.
Just to say, Joe, on I think it's page 13 of the contracting, there's other services are actually down 500,000 units of activity. What's actually in the other services? I think it's page 13.
Just bear with me, take my.
Sorry, it's page 31. Page 31.
All right, okay.
And you've got other services is actually down by about 500,000. It's a question of what's in other services.
Just bear with me, tick, Michael. I'll get
page 31.
It's okay. Can I come back to you, Michael, when my computer's catching up?
Doesn't involve. Okay, doesn't matter, Bill. Right. Yeah, that's okay.
I could share the screen if that would be helpful, Joe.
No, it's okay. It's all right. I'll put it in the chat for Joe to respond later.
Okay, I'll catch up in a minute.
Fantastic. Okay. Are there any other questions from anyone else? I mean, as you've just alluded to, Joe, it does feel as though there's a huge focus on the catch-up work across the whole sector, and that does feel as though that's our main focus on this, doesn't it, and on performance. Okay, if there are no other questions, it does appear as though section 10 we are going to have to leave. I don't know, Louise, did we get any other particular, is there any particular other things that are not in our papers that we have?
I have got the presentation from Public Health.
Was it a combined presentation between the two of them, or?
It usually is. I would think.
Yeah. So. Obviously, it appears there's been some mix-up with timing, so apologies, folks, that we don't seem to have that. I'm wondering whether we're best to email that round, unless we want to, as I say, just look through the slides. I don't know how we are best to do that. I don't think there's going to be anyone on the call that's probably able to easily do that for us. In which case, I suggest we just email those slides around if that's all right, Louise. And as Jeff said, as Gerald said, and Michelle, they're quite happy to take questions by email. So hopefully we'll make sure we get a good contribution from them next time. We're then onto the second page of our agenda, and I think we're on the strategic items, the annual workforce, human resources and OD plan. Joe, is your computer working again, or?
I'll get to. I was just going to answer Michael's question. Actually, I was just start doing the typing. There's an all mixed bag in there, Michael. A lot of sort of pathology services, that type of mixed bag. That's why the number and activity is so big. But as I say, it's predominantly pathology services.
Okay, thank you.
Okay, Joe. So are you able to take us through item 11.1?
Just bear with me, tick again.
Yeah, Michael, your hand's still showing up on my screen. Great, thanks. If that's causing problems, we could ask Neil to go through the risk register report next.
Yeah, that'd be helpful. I've just lost my suite of papers.
Neil, would that be all right to go through the risk register with us?
Will do. I'll share my screen very briefly because there's not a huge amount to talk about this time around, but 2 seconds. Hopefully that's just popped up. So there's been no material changes to the assurance framework. So our strategic risks are what makes up the assurance framework for the governing body this time around. Although I'll flash on some of the higher risks shortly. We just mentioned some operational risks that have changed in this reporting period as well. So we've been able to, or we think we were able to close the PPE, accessible PPE risk, and this was added at a point in time when this was the risk 12 months ago. But obviously we've got plans and procedures in place that has de-escalated that risk. So we think it's appropriate to stand that risk down. So we've taken that one off the risk register for now. There's an operational risk around cyber attacks, and we've increased that risk to a high risk, and that's not to say that there's been more evidence of risk or harm to the CCG on this. So we just had a conversation at Audit Committee and felt that actually the consequence of that risk could be really catastrophic. So we've reflected that with a risk review. So that's now captured on a 10. The likelihood is low, still more minor, but the I guess the impact could be quite catastrophic, so we just reflected that in the risk register as well. And that I'll flash up. These are the risks that are the red risks rated on the assurance framework, and we've talked about a lot of these already today. So some of the IAPT and mental health services, sustainability of primary care, and some of the performance challenges we've had that Joe's just talked about around, I guess, secondary care, but other cancer and A&E treatments. So not a lot of change, but just wanted to show it for completeness to say that there hasn't been that much change this reporting period.
Okay, thanks very much, Neil. Any questions from anyone?
Hi,
Go
Mark.
for it, Shanaz.
Yeah, just the risk with the IAPT services, because we're doing the work at the moment with the raw reimbursement with mental health. Do you think that'll have an impact in terms of the funding and stuff? Because the mental health trust going to be providing 50% of the funding for the new raw reimbursement, so will that have an impact on core services? Because it's supposed to be additionality, isn't it? It's not supposed to actually impact on core services.
I don't know
if you've got any answers to that one.
Yeah, so there are 3 additional sources of funding for mental health services this year. The Mental Health Investment Standard, as I've mentioned, service development funding, which used to be known as transformation funding, and spending review funding, which was just an additional £500 million nationally that was announced by the Chancellor just a few months ago. We've confirmed that the Trust can use money that is intended for them anyway to pay for their element of the additional role reimbursement. So in that sense, it should be additionality rather than just moving people around. So that's the basis on which we hope to go forward. But we very much want primary care networks to appoint as soon as possible primary care mental health workers. They're not designed to replace IAPT, and in fact in community transformation funding IAPT is very specifically excluded. So this is really to support primarily those people with more severe or enduring mental health problems, but also can be a first port of call. They're designed to be a first contact role. So I think there will be a great asset, but it will really require working together with the mental health trust providers, and certainly around the country where we've seen this work well already as a sort of prototype model is where the primary care mental health worker has a foot both in the community and in the established mental health services, and that's why the service spec for this role was designed in the way it was.
Okay, thanks very much. Michael?
At the audit committee last week, we had a big debate about the red risks that have been risks for a long time. And Bill Cunliffe's point was that when he does a CQC check of a provider trust, first question is, which are your outstanding red risks that you haven't managed to manage over the last few months? There isn't any answer to this, I don't think, but we need somehow to be able to tackle these major risks and show some kind of progress about getting these back into line again. I wonder whether we could raise this at, say, a development session later on as to how we actually manage these.
Yeah, I don't know, Joe, if you can give some thought to that.
Yeah, and as I say, we did dwell on it at audit committee, and we talked about risk appetite of the organisation and shifting that, and if we've got a red risk, what is the organisation's response to that? And probably a good idea to pick it up with development session as part of the risk appetite.
Thank you, Neil.
Just to say that we mentioned it, audit committee and quality safety and risk committee, we're looking at the risk matrices that we use to score risks, and we're looking to adopt the risk matrices that NHS England use for a couple of reasons. It's I think timely to review it, but also to get an equal footing across the ICP area about how we score risks. So we're a conversation with my equivalents in other CCGs, and we're trying to adopt a similar approach so there's more read across the patch, I guess, with one eye to 10 months time. And that will possibly touch on some of the risk appetite, because there's a level of granularity with the new risk matrix, because there's a red, amber, yellow and green categories, if you like. So we'll obviously bring that back. Well, we'll do the bit of work in the background with the policy to change or look at the risk matrices, but just to make governing body aware that when we bring this back in 2 months' time, we may be applying the new risk matrix, and as part of that, we can look at the consequences of the risks and the risk descriptions, just to make sure that we've got everything captured right. It gives another opportunity to review all the risks we've got on there, and just to make sure that we are confident that the likelihood and the consequence of those risks are scored appropriately.
Okay, thank you, Michael. Or is that an old hand? So it's an old hand. Okay, so with that suggestion, then, Joe, are we all right to pass you back to item 11.1?
Yes, I did have a moment of panic because it disappeared again, but no, but I'm good to go. So thank you,
Right.
Neil, for stepping in, and the governing body's forbearance. So this is the Q4 HR and OD report. It's actually the annual report because it's cumulative. In terms of staff and staff turnover, we have seen an increase in numbers of staff leaving the organisation. Q4 does tend to lend itself to a larger number of staff either retiring or ending fixed-term contracts, and we can see that being part of the reason it is outlined in section 2 of the report. Just to be clear, no member of staff in terms of the voluntary resignations have cited the impending changes as a reason for leaving. Moving through the report, section 3 covers demographics and E&D issues in terms of the workforce. Turn to section 4, sickness absence. As a CCG, we are slightly above the rest of the CCGs within our ICS area by way of sickness absence, and perhaps what is concerning is a re-emergence of S10. Anxiety, stress and depression as being the largest reason for staff absences, and it's probably fair to say staff are feeling the pressures of the service at the minute, and you know that is the service right across the board, but as I say, it is a re-emergence of mental ill health as a major reason of our staff absences. I'll talk a bit about the health and wellbeing at work programme of work in a minute, and it is covered later on the report. In terms of other aspects, there is a section under section 6.2 just about our COVID management of COVID and COVID sickness. We haven't had no COVID-related absences within Q4. We are moving to, in terms of staff electronic records, to a self-service. The intention was that we were to go live on the 1st of April with self-service. That has been paused as we are just trying to work through 1 or 2 teething issues, but nonetheless, the intention remains in terms of ESR self-service. Just picking up some issues about Better Health at Work Award. This is testament to the work of the health advocates, Chris prior to retirement, and to Julia sort of post-Chris's retirement. We have been granted the Gold Award. We are testing with staff, you know, where do they want to go now in terms of having achieved the Gold Award, but in essence, it was about what we do for staff, not achieving the award. There's a lovely picture in there of Marley May, who is Kelly James's daughter, who actually came up with a model of award. We were told that we needed to make our own award, and she kindly stepped in and made that model for us as an organisation. So a big thank you to her, and that's a lovely picture. And finally, within the the staff report. We just acknowledging Chris's retirement, and there's a couple of pictures there that of Mark doing a presentation to Chris, which is equally good. The appendices to the report is the Better Health at Work assessment, and we simply attached it for information, just to show to the governing body the depth of the assessment and the breadth of the assessment, and the work that the health advocates have done, for the organisation, but importantly for their colleagues. And a big thank you to all of those health advocates. I'll stop there, Mark.
Thank you. And any questions on that? I guess we should also just mention that the Better Health at Work is something we've now got a post in the organisation to try and support the rollout of some of the principles of learning here to primary care as well. So there is an active programme of trying to roll this out to partners, which is another way of using the learning we've got it within the CCG. Any other thoughts from anyone else?
Mark, can I comment? Sorry, I haven't got a
Go
hand
for it.
because I'm on the phone. So just picking up on Joe's point about, we got to the point of having the award. We're just in the process at the minute of undertaking a survey of staff. So if anybody's received the survey, if they'd like to fill it in, that would be really helpful. And we're very mindful that there's been different pressures in the organisation at different times, and what does it for one group of staff will absolutely incense another group, and you get quite peaks of reaction and emotion to this, because we've all been through a very difficult year and we're very mindful of that. So the survey that we're doing at the minute will help us to try and build on what's gone before, but also steer us through the next few difficult months, because uncertainty is really challenging for a lot of people. Some of us have been through change a number of times, other people it's new to them, and we need to find the best way we can support our staff on a number of different levels to get through to wherever we're going to end up at the end of next March. So it's just important that governing body members are aware of that.
Thank you. Michael?
Section 7 of the report talks about a joint meeting between the Gateshead Place staff from the LA and the CCG. I would hope that something similar is in the offing for the Newcastle side, because it isn't always easy to get people to work together. I think that will be one way of actually pushing that forward.
Okay, thanks for that comment, Michael. I'll leave.
We've previously presented. Sorry, Mark. We've previously presented a wonderful picture of all the Gateshead team. Sorry, the Newcastle team at Regent Point. From all of the partners. So there is work being going on in that regard, Michael.
Okay, thank you.
Okay, thank you very much. So I am assuming that we've now completed items on section 11 and section 12, and then it would just be if there's anything to highlight in any of the for information items. Obviously, we copy these each time, and we appreciate people are busy and may not always get to see some of the detail. But if there is any questions people want to mention about any of those reports and the process we have of attaching them, please do let us know. Assuming that there is not, and they are just there for transparency, that's fine. Are there any other items that people want to mention, any other business, and any other particular things that people want to include in our next governing body in July? Nope. I guess, Louise, can I just check if we've got a patient story lined up or a theme for the beginning of the governing body in July?
Don't think so. I don't know if Julia was looking into something. I'm not sure, but off the top of my head, I don't think so at the moment, but we'll get that sorted.
Because it'd be great.
Yeah, I'm on the case with that, Mark.
Fantastic. So that's great. So that's the case you've mentioned. Fantastic. That would be great. And obviously, if there are any other themes that would link in with that, Julia, do let folk know if you think there's others that we can weave into that. But yeah, it would be really good to get people's thoughts and contributions as to what would be a useful part of our governing bodies for future meetings. I think we've got Paul first, then Shanaz.
Yeah, it would be good to have something just thinking about risks in mental health services. The eating disorder service, something on that, and what's happening around it. And also, I think it'd be good in terms of mental health that we've never reviewed all our promises that we made around deciding together, which we did in 2016. So it'd be good to revisit that and see what we managed to do. against the kind of promises we made.
So you're saying thank you, Dominic and Catherine, for doing a great mental health update, but you're still on next time, and can they give you even more?
I know, I just hate them so much. I want to give them extra work. No, they did a really brilliant job there. So no, it'd be good to know those things as well, though.
Dominic,
And I
would
think
that
it'd
be
be good
something
for us
you
to
can
revisit
consider?
deciding together.
Okay, I'll leave Dominic to perhaps explore what the best approach to that would be with Catherine, if that's all right. Dominic, have you got any particular thoughts, or are you happy just to consider with Catherine what we do about those two requests?
Yeah, so I think the eating disorders one will be fairly easy because we are about to launch a service where we've never had one before. And there are specific funding lines for children's eating disorders as well. Deciding together, whatever the other acronym in that, the DTDT is a work I wasn't part of. I'm not sure how valuable it will be to just go and revisit that in its detail, though I am absolutely certain that the principles and the ideas that were generated by that work will be being taken forward. But I can discuss that with Catherine to sort of see whether we can easily translate from the past to the present in terms of what our priorities are.
I think that'd be
Jill
really
was heavily involved in that as well, Dominic.
Who, sorry?
Jill McGrath.
Yeah.
And a lot of that work was about what were the plans for ongoing changes to any specialist services. Then that may well now be caught up with the place-based plans rather than in the same way that we did then. Thanks for that, Shanaz.
Just to connect in with them, I'm really sorry I was late for the meeting because I was sorting some stuff out in the practice. So I'm sure you'll talk about the pressure in general practice at the moment and the impact on receptionists particularly, because I think receptionists are dealing with a huge amount of stuff that I think that never gets to GPs, but all we hear about is actually the pressure on GPs. But I just wanted to mention that actually the doing the Health and Wellbeing Award in our practice has made a massive impact on managing some of that, because we have a receptionist who leads it alongside other people. But actually just being involved in that in the initiative and actually organising events, connecting with people has had a huge impact on actually the morale within the practice, and it is having a tangible impact. And we're just going into the Silver Award. The other thing I just quickly wanted to mention was that actually, as Gates said, PCNs, we've just managed to secure some support from the Time for Care programme, which I was trying to do last year and we couldn't because for some reason region, anyway, whatever the mechanisms are, eventually we've managed to get through and we're going to do some work around shared purpose and how do we work together strategically, but doing that work, having the external support and facilitation, which is funded at a national level, will really help us to actually then think through how really sort of galvanise our connections with the Gates Assistant Board. And Lynn, I'll probably talk to you about that separately if that's okay.
Okay, so I think that's a really good point. And Shanaz, I did mention in the previous one about the Be Kind campaign as well, recognising that receptionists are taking a lot of grief at the moment from people unhappy with specialist waiting times and various other issues. So I've just put that link in the chat function if people haven't heard of that campaign, which is now across North Tyneside, Gateshead, as well as Newcastle, where it was started. In terms of that work, yeah, it may well be appropriate for us to think a little bit more about whether there's an update to governing body, whether it's in the development session or elsewhere, of some of that work around primary care and what you've mentioned there, Shanaz, but perhaps we can pick that up offline. Yeah. Okay, I'm aware that some folk need to go to the next meeting. Is there anything else people want to mention for now? In which case, can I say a huge thank you to everyone's work that goes on. It's a huge mammoth effort to get these meetings going. A lot of work in the background, but I'm really grateful to everyone and thank you for everyone's participation today. Take care, everyone. We'll see you.
Thanks, Mark.
Bye. Take care.
Bye.
Thank you. Bye.